Hello and welcome to the Retina Radar podcast. I'm Arshad Khanani, Managing Partner and Director of Clinical Research and Director of Fellowship at Sierra Eye Associates and Clinical Professor of Surgery at the University of Nevada, Reno School of Medicine in Reno, Nevada. In each episode, I'll be sharing information on the latest breakthroughs, clinical insights, and practical pearls for your everyday use. We'll hear from leading experts, explore cutting-edge research, and discuss the trends shaping our field. Whether you're in clinic, in surgery, or on the move, Retina Radar keeps you informed, inspired, and ahead of the curve. To earn CME credit, visit mededtalks.com, search Retina Radar, or click the link in the notes to complete the activity and post-test. Before we begin, please review the faculty disclosures and learning objectives. If you have a question for our experts, send it to us at cme@vindicocme.com, and it may be featured in a future episode. This podcast is supported by an educational grant from 4D Molecular Therapeutics, AbbVie, Adverum Biotechnologies, Alkeus Pharmaceuticals, Astellas, EyePoint Pharmaceuticals, Genentech, a member of the Roche Group, Neurotech Pharmaceuticals, Ocular Therapeutix, Oculis, Regeneron Pharmaceuticals, and REGENXBIO. Today I'm joined by my good friends and colleagues, Dr. Margaret Chang from Retina Consultants of Sacramento and Dr. Andreas Emanuelli from Emanuelli Research and Development in Puerto Rico. Welcome, Margaret and Andreas.
Thanks for having us.
Thank you, Harshad. Thank you.
I'm really excited to have both of you here today because you are deep into clinical trial design, you're deep into clinical trial execution, and you are involved with all the latest innovations that are happening in our space. And I know it's a very exciting time with so much innovation and a lot of trials reading out in the next year or two. So today we'll be discussing the mechanism and clinical data from tyrosine kinase inhibitors that are in clinical development, especially in phase 3 programs. But before we do that, we get the podcast started by asking a few questions about yourself. Margaret, we are welcoming you back to Retina Radar. I think you were on last year, correct? Or the year before?
Yes, happy to be back. Thank you.
So I think our audience know your story already, but let's summarize it again. Tell us how you ended up doing what you do, being a vitreoretinal surgeon.
Started off as a piano performance major in college, decided to go to med school, wanted to be a pediatrician, decided to be a cornea specialist, and saw submacular surgery and decided to do retina. So that's in a nutshell.
That's a really good summary. And is that true? What age did you go to med school?
I had just turned 19, so a little bit earlier than everybody else, but yeah.
Yeah, quite early. So that's great. And tell me about your hobby. I know your kids do fencing. Are you fencing or no?
No, those are my kids. I am definitely just the wallet that makes it happen. And I do love supporting them at their tournaments. I'd say my hobby now, other than piano, is going to be baking. So I love to tinker with new recipes and make all sorts of not very nutritious things for people to enjoy.
Okay, I love that. I have a sweet tooth, so maybe we can do like a reunion of some sort. We can all bake some stuff. I'm not good at baking. I like to cook. Not great at it too, but maybe I make the entrees and you can make the dessert. And when we have a big retina party celebrating an amazing year coming up for our field next year. Okay, Andres, tell me about your journey to being a vitreoretinal surgeon.
Yeah, so I did my med school in Puerto Rico. At some point, I was about to be an orthopedic surgeon. But I entered into the ophthalmology OR, I saw retina surgery and I saw the light. So I just decided to do ophthalmology and then went into the retina that gives like the perfect balance between surgeries and science. And I really love it.
No, that's great. And what are your hobbies? Spending time on the beach or?
Well, that's part of it, living in the island, but I don't know if you know that my daughter is pursuing like a Latin pop career singer, so I'm like studying a lot of music business, music production. So it's something very different. And my kids play soccer, so I really enjoy that.
No, that's great. And you have been in Puerto Rico in your practice for how long? You went to Bascom, then you went
Yeah.
back to Puerto Rico, started there,
Yeah.
right?
So I started at 2012. So yeah, so it's been 13 years.
And you built quite a impressive research department. I know you cater to, they're lucky to have you in Puerto Rico, and you cater to a very large patient population, especially a lot of diabetics, for sure. But you really have made an impact, in clinical trials for sure. I always hated when I lose to you in enrollment, but it seems like it's pretty common that you always beat us in enrollment in majority of the trials, especially diabetes trials. So no, I think you're providing great care, and you should be very proud of what you have built there. So, okay, so let's get to topic at hand. Margaret, starting with you, tyrosine kinase inhibitor, exciting or another not very exciting story that will not uh, be meaningful? So tell us a little bit about tyrosine kinase inhibitors, and especially Vorolanib and Extranib, that are in phase 3 development.
So I think tyrosine kinase inhibitors are super exciting. Otherwise, we wouldn't be on this podcast today. So they're very molecules that diffuse directly into the cell and work intracellularly to bind and block the tyrosine kinase class of receptors. So that is going to include all of the VEGF receptors as well as PDGF, and therefore there are multiple targets of action.
Andres, tell me about your thoughts on tyrosine kinase inhibitors, especially how they will compare to other treatments that we have, like longer acting intravitreal injection, the port delivery system. So what do you think they will fit in?
Yeah, I believe it's a very interesting therapeutic agents that I see them as mostly as to have like a good maintenance during treatment, like to have like a steady dose of medication. Maybe we can at some point do like some to induce with anti-VEGF and then maintain the durability with these TKIs. I think is the good things about them is that they're like implants that can be injected instead like a surgery when they comparing it to the PDS. So it's simpler. It's an office-based procedure, and I think it will be great for patients. It's proved to be great.
Yeah, no, I agree. I mean, I think any in-clinic treatment obviously is welcomed by physicians because it's just easier. Obviously, we also look at the safety and efficacy and which patients benefit the most. And I agree with you. I think there are maintenance agents, right? You control the disease with bolus injections, and then you decrease that treatment burden significantly by introducing TKIs. So instead of a patient coming in to get injections every 2 months or so, they can now go 6 months, 9 months, or even longer. So I think that's why it's exciting to me. And as Margaret said, I think it's a pan-VEGF intracellular inhibition of VEGF receptors. And I think it's one of those things that our field is very excited about. In terms of tyrosine kinase inhibitors that are in late stage development, I think the focus we'll have today will be two different ones, Vorolanib and OTX-TKI or Extranib implant. So let's get started with the first program, Vorolanib. So Andreas, you've been involved with many early, mid, and late stage studies. So tell us a little bit about the program in terms of Vorolanib and what kind of data we have seen to date in neovascular AMD as well as DME, and then what's currently ongoing in the phase 3 Lucia and Lugano studies.
Yeah, so Lucia and Lugano study right now are fully enrolled. The DME program is advancing to phase 3. So in terms of the results for the phase 2, the DAVIO study, the BCVA change was practically identical to the on-label aflibercept treatment. So I think that's great. And in terms of CST, the Vorolanib was a little bit higher. It was 21 microns versus 11 microns. So there were no significant SAEs and no migration or retinal vasculitis. I think in terms of safety is great. And in terms of DME, the Verona study met the primary endpoint to extend the supplemental injections. 64% of patients remain supplement-free at week 24. And there, in terms of safety, was also great.
Andreas, that's a great overview of the DAVIO and Verona studies and clearly exciting data set that we have from both of those trials, which is leading to, obviously further development of Vorolanib for treatment of wet AMD. As you said, the phase 3 trials are fully enrolled, and the plans have initiated to start DME phase 3 in the near future. Margaret, so as Andreas said, the results we got with EYP-1901 or Vorolanib implant was very similar to aflibercept every 8 weeks. And this was achieved, obviously, in DAVIO study with a single implant. What about treatment burden reduction in these patients? What are your thoughts on that? And what did the trial show?
Well, this is definitely a huge issue for our patients. The need for repeated treatments does lead to eventual vision loss in a lot of them because there are, lapses in treatment that can go forward. So in the DAVIO study, there was an 80% decrease in treatment burden, and that's quite significant, of course. And then in Verona, of course, 64% of those patients were supplement-free at week 24 in the higher dose group. And so that's huge. If we can decrease this treatment burden going forward, I think that eventually, our patients will not only have better quality of life, but hopefully a better chance of maintaining their vision long term.
No, I agree with you. I think, reducing that number of injections and number of visits obviously will be huge in terms of improving long-term outcomes. Andres, you see a lot of diabetic patients with DME, and the compliance is pretty poor in those patients. You think if EYP-1901 is available, I think it's going to help your patients with DME, hopefully maintain long-term disease control and hopefully better vision outcomes?
Yeah, I do believe that. Most of the complaints of the patients are the treatment adherence, like they need to have frequent injections, and they're always asking me, "When's the last injection, doctor? Are we done? Are we done?" So I'm pretty sure once you give them like a long-term option, they will be really happy and they will have a lot better control of their disease.
And Margaret, what about safety of EYP-1901 in neovascular AMD and DME? Anything that stands out from your
You
perspective?
know, we're always super concerned about safety for inflammation, vasculitis, anything like that. And there really was no safety signal seen. So no problems seen in either Verona or DAVIO. And there was no implant migration. That's always something that we also worry about as well. So very clean safety signals for both of these trials.
No, I agree with you. I think safety is our priority. And so far to date with EYP-1901, there's been no safety issues that we have seen. Obviously, the phase 3 trials are ongoing, and we expect to see results next year. So it's going to be very exciting to see this data set. Now, let's move on to the next program, OTX-TKI. This is a hydrogel that has Extranib. We also have a suprachoroidal program with CLS-AX that also Extranib. And obviously, Extranib has been shown to be very potent TKI. And now, obviously, in the OTX-TKI program, it's in phase 3 SOL-1 and SOL-R studies. These trials were designed based on the data from the US phase 1 study with Extranib. Margaret, do you want to share with our audience the design and results from that study?
Sure. So for that phase 1 US study, there were 20 treatment-experienced neovascular AMD patients who were randomized to a single dose of OTX-TKI versus aflibercept every other month. And they were followed for a year. So they found that a single administration of OTX-TKI was able to reduce treatment burden by 89%, which is, quite extraordinary. And through week 40, 73% of patients did not require a rescue injection. So there was good maintenance of visual acuity and anatomical control. And again, safety was excellent. There were no cases of inflammation, vasculitis, or implant issues as well.
That's very exciting data set, Margaret, for sure. And I think this data was used to design the SOL-1 and SOL-R studies. Obviously, they're both different trial designs. Usually we're used to phase 3 studies that are very similar. But in this program, they're actually two different studies. So, Andreas, can you share with our audience the design of the SOL-1 and SOL-R studies?
So one is a superiority study comparing aflibercept 2 milligrams to OTX, where you receive 2 loading doses of aflibercept, and the rescue treatment is when patients lose 15 letters, and the readout is at 52 weeks.
Yeah, that's a very interesting design, right, Margaret, where you have, you know, 2 loading doses given in both arms, then randomize to give OTX or aflibercept, and then just observe these patients. And the study was designed based on the regulatory feedback, and it actually has a special protocol assessment or SPA from the FDA, and primary endpoint, obviously, at 9 months, but the top line readout will be at 52 weeks, and it's a 2-year study. So, Margaret, as a clinical trialist, what are your thoughts on this study? And I know you participated in it, and how did the recruitment go for you? Obviously, this is fully recruited, and we're expecting top line data next year.
I think this initially, this is not the trial design that we're used to. It definitely is unique. And it seemed that, there were some initial hesitations about going forward with recruitment, but because the patients had to improve at least 2 lines or to 2025, the amount of vision that they had to lose was actually not really 15 letters. So this was basically a situation where the patient safety was still intact. And I think once we understood that as investigators, it was much easier to enroll.
Yeah, I think that's a really good point that you're losing 5 letters from screening because you couldn't get into the study unless you gain 10
Correct.
letters or got to 20/20 vision. So yeah, I mean, I think but this is a real study comparing real durability in that sense, right? Like we have other studies where the study arm get extended while the comparator is fixed, and sometimes it's hard to know the exact durability. So we will see. I mean, OTX-TKI, how long it can control disease in these patients. And then now let's move on to the SOL-R study, which is more of a traditional study, but it is a 3-arm study. So, Margaret, can you share with our audience the design of the SOL-R study?
Sure. So 3 arms after the loading doses, they are basically randomized 2 to 2 to 1 to OTX-TKI, single dose versus aflibercept 2 milligrams every 2 months versus 1 dose of aflibercept 8 milligrams. Then after 24 months, the OTX-TKI and 8 milligram doses are redosed. So this is more traditional. This is a non-inferiority study. In terms of the sham, again, it's going to be the OTX-TKI and the aflibercept 8 milligrams that have the similar types of dosing. So still a unique trial design, but one that we're a little bit more used to.
No, I agree. And I think the one thing about this trial that is different is that, 6 months run-in period where patients have to show stability of their CST. And if they are not stable, then they're not, randomized in this study. And I think this was designed keeping in mind that, TKIs will be maintenance agents. And as Andreas was saying earlier, that I think we're still going to be using anti-VEGF to control the disease initially and then use a TKI to get much better durability than we can do with the current agents. So yeah, very, very, exciting time with OTX-TKI. Both of these trials are fully recruited, and I'm looking forward to the data from these trials. Now, let's move on to the Helios study. Just quickly, diabetic retinopathy. Andreas, tell me about how bad diabetic retinopathy is in Puerto Rico, and having an implant that can be injected every 6 months or every 12 months to control diabetic retinopathy, how meaningful that's going to be for your patient population.
Yeah, that will be great. I mean, diabetic retinopathy in Puerto Rico is very prevalent. We see a lot, and there's a lot of worsening of that to PDR and to sight-threatening complications. And I think having an implant once a year or twice a year will be a great addition to our therapy to offer to the patients.
So in terms of the data from the Helios phase 1 study, Margaret, what is the most exciting data set from that program for you with OTX-TKI given once and these patients followed for a whole year?
Well, yeah, I mean, it basically showed that in these patients with moderately severe to severe non-proliferative diabetic retinopathy, that there were no patients that developed vision-threatening complications. So those, that's really what we worry about as clinicians, right? Are they going to come back with diabetic macular edema? Are they kind of going to come back with, vision-threatening vitreous hemorrhage, things like that? And it was able to show that with just one dose, it really protected the patients from developing those through 48 weeks.
Yeah, I think that's a very important point, Margaret, that you made, because, as a clinician, my goal is to stabilize the patients and not getting worsening disease because we are worried about the vision threatening complications. So whether they improve one step or two step, I think our goal is to avoid patients from getting worse and getting those vision threatening complications, which nobody had in the cohort that was treated with OTX-TKI. So very exciting data. And as we know, recently it was announced that Helios 2 and Helios 3 program will not launch in the near future, and it obviously has a new endpoint called the ordinal DRSS endpoint, which is actually taking into account stabilization, worsening, and improvement instead of the traditional two-step improvement primary endpoint, which we had for a long time. Obviously, in that endpoint, you don't count patients who are stable or one-step improve or worsen over time. So I think this ordinal endpoint is very exciting for the field, I think, for the future of diabetic retinopathy trials. Andres, you're part of many of the diabetic retinopathy trials. What are your thoughts on this new novel ordinal DRSS endpoint?
Yeah, I think it's great. I think it's more clinically relevant. So you want patients to be stable. You don't want to get them worse. So I think it's a great measure.
No, I think it's very exciting. So we'll see, how the data from the phase 3 programs look like. They haven't started yet, but in the near future. So very exciting time for our field to have 2 programs in phase 3 development for neovascular AMD, a disease that's very common, a disease where patients lose vision over time because of undertreatment. 50% or so are discontinuing treatment over time. And so I think TKIs really can unlock, this durable treatment that hopefully can optimize outcomes for our patients. Obviously, we have to see the data from phase 3 programs in terms of efficacy and safety to see how these treatments are going to fit into our clinical practice. So before we close our podcast, I know we can spend hours discussing TKIs and other innovations in retina, but we have limited time. So we always ask our faculty about the achievements they're very proud of. So Andreas, I will ask you about, the achievement that you're really proud of in terms of your career. I'll tell you that you built an amazing research department and practice in Puerto Rico. And what I like about you is you actually went back to where you train and you're providing service to people that are underserved. So it's very impressive what you have done. But tell me, what are you proud of from your career so far?
Yeah, thank you, Arshad. Yeah, that's my main achievement. I think building a research center in Puerto Rico and giving that access to our patients from antibody therapy up to gene therapy devices. It's been a great experience. Patients are doing great. It really impacted our population. So it's been great.
Great. No, I agree with you. And on top of that, obviously now you're going to be a music producer and you're going to be holding concerts for your talented daughter. So I'm sure that's something you're going to be very proud of, because I know Margaret is very proud of her son's fencing and winning all these titles around the world. So Margaret, tell us about yourself in terms of what are you most proud of?
I'm proud of being an early woman in private practice retina. I'd like to say that I've had the fortune to do it all. So, I'm a busy mother of three. They are incredible boys that I'm super proud of growing up to be fantastic young men. And I'm able to stay involved in their lives, but I'm also, obviously very busy in private practice, doing lots of clinical trials, doing what I love. So very, very lucky to have it all.
Well, I don't know how you do it, Margaret. I'm always impressed. You're doing those 5 a.m. CME events with me at meetings. You're doing late night. You're managing, family, and you're always so eloquent on the podium. And any chance you have to do a presentation, so really impressive. For me, I can do only retina. I'm not doing everything else. And, my wife is the one who's actually leading the way at home. So it's very hard to do both. And I think you have really shown us that it can be done. So you're incredible. And we always love to have you on Retina Radar. So last question. You guys, both of you are not retiring, but how do you want to be remembered? Real quickly, Andreas, followed by Margaret.
Yeah, so I want to be remembered as um, a surgeon and investigator that opened that door for Puerto Rico for clinical trials in ophthalmology. So it's been a great opportunity. So that's how I want to be remembered.
Yeah, I mean, you should be very proud of what you have built, and I totally agree. And on top of that, I'll always remember you as a very nice guy, and you're
Thanks.
always so humble and kind and always smiling. Margaret?
Uh, you know, uh, I think I already said it, but I'd love to be remembered as a kick-ass woman who could do it all.
Yes, very well said, and also very nice and eloquent, and always ready
That's
for
right.
game time. So thank you both for coming to Retina Radar podcast. It's a pleasure to learn from both of you, and I also want to thank the audience for tuning in. Thank you, Andreas. Thank you, Margaret. To earn CME credit, visit mededtalks.com, search Retina Radar, or click the link in the notes to complete the activity and post-test. Have a question for our experts? Send it to us at cme@vindicocme.com, and it may be featured in a future episode. Stay tuned for future episodes in the Retina Radar series to keep up with the latest insights and expert discussions.